For joining us today. We are very excited to be putting on this evening session. I'm Doreen Addrizzo-Harris, and I have with me this evening one of my dear friends and colleagues, Dr. Jamie Rutland. So we're going to be doing stories behind the science in non-cystic fibrosis bronchiectasis. We're going to talk a little bit about the disease burden out there. Hopefully you know a lot of what I'm going to tell you initially, a little bit about early diagnosis and bronchiectasis, and then looking towards newer management options that Dr. Rutland is going to tell us about. If you haven't already, please complete the pre-event survey, and thanks to Peer Review for providing this session and for INSMED for providing the educational grant for this symposium. You will be able to submit your questions at the end, and we will have about a 10-minute Q&A. So please do that throughout the hour, and then we'll try and answer as many of those as possible. Here's also the link to peer review. The slides and practice aids are there. You can download them and have them available to you after the event. So our goals for this evening are to define the burden of non-CF bronchiectasis, particularly on patient quality of life, its clinical course, and some of the unmet treatment needs, to teach you about the diagnosis and how to accurately ask your patient about their symptoms and what we need to be looking for risk factors and CT imaging, to describe how recent insights into the role of neutrophilic inflammation is extremely important and correlates to some of the emerging therapies, and then to show you how to best select some of the treatments that we're going to be discussing this evening for patients so we can reduce disease progression and hopefully improve their quality of life. So I'm at NYU Langone Health, and I am one of the co-directors of our bronchiectasis and NTM program, and very happy to do anything in education on bronchiectasis and NTM. So a little bit about bronchiectasis. Non-CF bronchiectasis, as many of you probably know, is an abnormal, usually permanent dilatation of the distal bronchi and bronchioles. In these patients, we see impaired mucociliary clearance, we see retention of secretions, and then we see recurrent infections, inflammation, and further airway damage. Here's a classic CAT scan showing bronchiectasis in the right middle lobe, and we've got some atelectasis and bronchiectasis here in the lingula. The prevalence is on the rise. This reference where we're looking at a total population in the U.S. Of 350,000 to 500,000 in adults was from 2017, and we know it's probably much higher than that because the prevalence has been increasing at 8 to 10% per year in some areas. We know, as you can see from this slide, which was from about 10 years ago, that it's really affecting the aging population with increased prevalence, particularly in women over men. It's heterogeneous. That's part of the problem in treating these patients and often in developing some of the clinical trials because there's not one exact patient. They look different. Their symptoms might be different. Their severity of symptoms might be different. Their underlying etiologies, we'll go over that, can be numerous and very different from each other. They have many comorbidities, and then the frequency of exacerbations can be different. So trying to define cohorts of patients that are similar are extremely important here. We know that many patients may be asymptomatic when they're picked up, but others have progressive cough, have progressive CT findings, have progressive of increasing frequencies of exacerbations. Many start out with one pathogen, develop a second, sometimes have 3, 4, 5 pathogens. and then some have significant loss of pulmonary function and have exertional limitations that increase over time. There are many etiologies. I like to break them up into diffuse versus focal. In diffuse, we often see a lot of the genetic variants. Cystic fibrosis, sarcoidosis can go on to have bronchiectasis, autoimmune disorders, particularly we can see this in rheumatoid arthritis as well as in a lot of the inflammatory bowel disorders, immotile cilia syndromes, post-transplant, HIV disease, and then chronic aspiration, particularly if we're seeing lower lobe disease, either upper airway swallowing difficulties or asymptomatic GERD. In focal, post-radiation, as you know, sometimes there is a foreign body causing mechanical obstruction or a stenosis. We know that non-tuberculous mycobacterium is often found in these patients, often in the middle lobe and the lingula. If you see that, you're going to be thinking about MAC or M. abscessus in the US, and then post-infectious, post-TB, often leading. When you see central dilatation and central bronchiectasis, predominantly you're going to be thinking about ABPA or cartilaginous syndromes. But even when we do very extensive workups, lab workup, genetic testing, et cetera, we're still left with about 40% of patients that have an unknown cause of their underlying bronchiectasis. So what are the risk factors? We know older age and females will have a higher prevalence. However, if you're male, you're more likely to have a more progressive form of bronchiectasis, so I'm sorry about that. But comorbid lung diseases are going to put you at risk, prior infections, we said autoimmune, immunodeficiencies, alpha-1 antitrypsin deficiency, immunoglobulin deficiencies. We talked about some of the others on the left hand there. And then you're going to go on to have an increase of death in patients, particularly who are older and who are male, who have other comorbid lung diseases, asthma, COPD, pneumonia, and lung cancer. What symptoms are most challenging in your patients? Many of them are going to complain about cough and productive sputum, but you can see here that fatigue is also a very, very difficult symptom for patients, more than 70%. You can also see that areas that pulmonologists may not always focus on, sleeping problems, anxiety, depression, all very high rates, 40 to 60% in patients with bronchiectasis. So we really do have to spend time and ask patients about these other areas because they really can affect their quality of life. And a lot of this data comes from the European data from EMBARC. So at this point, we're going to stop and just talk a little bit about a case. This is a patient of mine from New York, although she doesn't actually live in New York. She comes to travel and visit me in New York for her visits. She's a postmenopausal woman with a history of multiple bronchial infections, and she didn't have good access to tertiary pulmonary care where she lived out west in the US. So she ultimately flew to a number of different centers in the US to get care. But at the beginning, her symptoms were a progressive cough that was occurring over several years, purulent sputum most of the time, fatigue, and night sweats. And every time she went to see her primary care physician, or she eventually had a pulmonologist in her community, she got treated for bacterial bronchitis, sometimes with a macrolide, sometimes with a cephalosporin. At times, she got better a little bit, but shortly after, a week or two later, symptoms were coming back. She did have a chest x-ray that was read as normal, but this went on for years, for more than 10 years in her case, and she was having 2 to 3 of these exacerbations that were treated with antibiotics for years. She never had any sputum culture sent, and she never had a CAT scan. So at this point, I want to ask Dr. Rutland, because he knows the answers to every question. Why does this happen? Why does this happen? And for her, I mean, we're in 2024 now, so this all started probably 2013, 2014. Why was it happening back then?
What a great question. Well, I was training back then. So, when I think about questions like this, I often have to think about the timing. Like, is it time, or what I heard in your story was she had gone to multiple centers to see multiple physicians. Now, I don't know if that played a role in her not being able to be completely worked up. I think that, at least from me, from my training at KU Med and University of Iowa, it was beaten down into me that when you continue to see patients that present with similar symptoms, you have to think a little bit deeper, and you really need to work these patients up for a number of things, for a host of things, right? I do know that in my community, some of my colleagues are really, really busy and may not do certain things where they might not look at the CT scan, but they may just see the patient and look at the radiographic read quickly, look at the impression, not look at the whole report. I mean, there are multiple things that could be contributing to this, but I think, mainly when I think why this happens, honestly, I really feel like it's just they think it's bread and butter. Oh, it's pneumonia, give them antibiotic. Oh, patient got better. And then they just don't think about that return visit if the patient makes it back. I can't say. I would hope this wouldn't happen today.
Right, and unfortunately, sometimes bouncing around from physician to physician, and it's not the first time. It's the first time for that physician seeing a patient. If they don't have a very detailed history, they may say, oh, probably just a viral infection or bacterial bronchitis. But is it time? Is it that the physicians don't have the time to work the patients up more thoroughly? Why not send sputum cultures? When you have someone with purulent sputum, the first thing I want to do is get 10 sputum cultures. And I think it may also be access to resources. And how easy is it for some of the community physicians to send sputums? I don't know, but that might be it. But again, also thinking that perhaps a normal chest X-ray, is enough. And we'll talk about that a little bit as to that. Obviously, chest X-ray alone is not enough in these patients. And I do think that having access to care to some of the more tertiary centers is great, but we're hopeful that, now 10 years later, if she would have presented with these recurrent infections, the time to diagnosis for bronchiectasis would have been much shorter. And hopefully sessions like tonight and a lot of the sessions here at ATS are going to spread the word, and people are going to say, yes, non-smoking female who has now had 2 or 3 episodes of bronchitis, let's start thinking beyond that. And it's not always asthma. It's not going to be COPD. Let's think about what else it could be. Do you want to add anything else, Dr. Rutland, before I move on?
I just find it interesting that, honestly, I look at this case and I'm like, they were given an antibiotic and nothing was done. And I'm just like, not even a CT. Like in my practice, in my life, if a patient comes to see me, I'm probably going to order a CT. It's something that's just normal within my practice to at least understand the lung architecture. So when I saw your case and I saw the example, I was just like, wow.
Well, I think part of it is that sometimes when patients have exacerbations with or without antibiotics, they sometimes improve. And then they don't have that 3 months of chronic cough that then would trigger you to go ahead. So there's this roller coaster effect where they are sometimes improving, then getting a little worse, then getting better. So and the progression sometimes can be fairly slow. So that's why there's not this urgency at times to go ahead and do a more exhaustive workup. So let's go on and talk about some of the unmet needs in non-CF bronchiectasis. We know there's definitely a lack of recognition. We know there's an increasing prevalence. We know there are a lot of misdiagnoses. Patients are diagnosed with asthma, then put on inhaled corticosteroids, and we know that only increases the risk of complications, particularly infections and non-tuberculous infections. We know that there's a lack of standardized referral for a lot of these patients, perhaps, to centers that can provide further workups. There has been a lot of lack in approved therapies for these patients. It's not on this slide, but there's also been a lack of education of many of the physicians in the community on how airway clearance plays a very large role in these patients. Doctors were not being taught that during a lot of their training. If you see someone from infectious disease, and there may be some infectious disease doctors here in the room, that's not the first thing someone who's not a pulmonologist thinks about sometimes in caring for these patients. So again, it's really educating physicians about the 360 care of these patients that go beyond just antibiotics. And then suboptimal treatment of Pseudomonas. I know many of you have patients with Pseudomonas and recurrent Pseudomonas. What's out there to treat them? What do you do when things don't work? What do you do when they can't tolerate the treatments? There's a lot greater need now for more evidence-based trials on interventions in these. This is just a slide looking at how long the delay has been in a number of publications, and these studies, go back to the 1990s, but, one of them is as recent as 2017. So there's many years delay in diagnosing patients who have underlying bronchiectasis, which I hope after tonight's talk is going to change, and we'll have an immediate diagnosis next time you see a patient that you're concerned about. And we know that there's increased prevalence based on a lot of the patients we're seeing who are asymptomatic because of the cardiac CT studies that are being done by cardiology, lung cancer screening trials. A lot of these patients have underlying bronchiectasis as an incidental finding, and sometimes are not referred. And then by the time we may see them, it's been 3 or 4 years, and oh my, that bronchiectasis that was on their lung cancer screening CT has now significantly progressed. We also know that minorities are very underrepresented in most of the published cohorts of patients with bronchiectasis in the US. How does that change the prognosis? Do the etiologies change depending on which group we're looking at? So there has been a push to expand access to patients who are coming from underrepresented areas. When to suspect bronchiectasis? Well, obviously we talked about chronic cough and sputum, certainly in a non-smoking patient, when exacerbations are becoming more frequent. And then if we send sputum cultures, we'd start to be surprised. Why is someone who is supposedly just a relatively young, non-smoking individual have Pseudomonas in their sputum? Haemophilus, staph, stenotrophomonas. When you start to see aspergillus, we can go on down the list. Unusual organisms should be a clue to wanting to work those patients up further. And then presence of one of the common underlying diseases that we talked about as far as possible etiologies. So non-CF bronchiectasis is a clinical diagnosis. This comes from James Chalmers and Stefano Aliberti, where you not only have to have that beautiful signet ring, which all of you can see here, beautiful signet ring. We've got a beautiful pearl on top of, which is our pulmonary artery branch, on top of a beautiful bronchiole here. And you can see how large that bronchus is compared to the collateral, to the pulmonary artery that's traveling with it. And so there are many ways you can use the inner airway to artery diameter, or you can use the outer airway diameter. But when you see that the airway is greater than 1 compared to your pulmonary artery, and you see it in multiple cuts on multiple areas, multiple lobes on the CAT scan, you're fairly confident in making a diagnosis of bronchiectasis. And then your patients need to have at least 2 of the following: cough most days of the week, sputum production most days of the week, or a history of exacerbations. And those 2 together would give you a clinical diagnosis. A lot of this is being used for clinical studies, so that we're making sure that we have patients that have truly a clinical diagnosis of non-CF bronchiectasis. Here's why we don't just use chest x-rays, and why we should be looking at chest x-rays on our own. I love our radiologists, but we should be that second person looking at our CAT scans. So this actually was read as normal, and I would say it's probably not normal. We can see there's a little bit of increased markings here in the right mid-lung and actually in the right lower lobe. But if you do a CAT scan on this patient, and this is the corresponding CAT scan, you can clearly see there are significant areas of bronchiectasis and bronchiolitis, not only in the lingula and the middle lobe, but we can see there's bronchiolitis in the lower lobes on both sides. So you really need to get a CAT scan in these patients, not only to make their initial diagnosis, but to follow them. And certainly if you're treating them for either chronic Pseudomonas infection or if they've got NTM, there should be a logical follow-up CAT scan to see if they're improving, along with sputum analysis and pulmonary function testing. So now on your iPad or virtually, if you're joining us virtually, there's a question that you have to do before we move on that will pull you a little bit on the risk factors and diagnosis of non-CF bronchiectasis. So you can go ahead and do those questions. Can we go back a slide? One more. So I want to talk a little bit about the bronchiectasis severity index. Again, this was published about 10 years ago, but you would be pretty amazed at how many people are totally unaware of it. From Dr. Chalmers in 2014. And so this is just a nice scoring tool that you can use when you see your patients. It not only helps you determine how severe they are when you first see them, other than just your gestalt of saying, oh, that person looks bad. We can get an exact number. And then it's also valuable so you can give the patient some evidence-based information as to what their prognosis is going to be. So we see that age is very important, particularly if you're over 70 or 80. The higher the number, the worse the prognosis. BMI, extremely important. In our bronchiectasis center, a nutritionist is absolutely essential to the team. We see much more frequent progression in patients with low BMIs. So sometimes using our endocrinology nutritionist doesn't work because they're often dealing with BMIs over 30. It's a whole different tactic in dealing with a lot of these patients. And they often also have other diseases, sometimes eating disorders as well, that need to be addressed. The FEV1, very important certainly as you get to the moderate to severe numbers. Previous hospitalizations, if you've been hospitalized for a pulmonary infection, already have 5 points, which you'll see puts you into the moderate group already. Severity markers, exacerbations per year. We know that patients with greater than 3 exacerbations have progressed, have an increased mortality. And so that's extremely important. The MRC breathlessness score, another factor that you're going to want to figure out for the severity index. If you have Pseudomonas, again, we know Pseudomonas is not a good prognostic sign, and so that counts for 3 points. Colonization with other organisms, not as much data out there for the H. flu, the Aspergillus, the other things you see, but if you've got multiple organisms, you're going to get extra points. And then the more lobes that are involved, the worse the prognosis. So if you've got 6 lobes involved, then you're really going to be at a much higher risk than somebody who might only have 1 lobe. And so when you look at the score, if you've got 0 to 4, you're in the mild range, 5 to 8 moderate, and greater than 9 would be severe. And you can see how different the mortality rates are based on where you score, 0 to 3 at 1 year for the mild, up to 1 to 7 in the moderate, and then for severe, look how high that is, 16 to 52. These are the hospitalization rates, excuse me. Mortalities, again, go up sequentially as well. 0 to 2.8 for mild, 0.8 to 4.8 for moderate, and 7.6 to 10.5 for the severe. So you can kind of give your patients an idea of where they are in this spectrum. And perhaps treatments will lower them. We don't have that proof yet, but might lower them to one of the lower levels, and then that potentially would allow them to want to be more active in some of the treatments that we would recommend. So here's another trial from James in 2018, which really looks at the number of exacerbations. So as you increase the number of exacerbations, your hospitalizations are going to be increasing. And we see how number of exacerbations affects survival. So then greater than 3 exacerbations is going to be having worse survival over 5 years. So again, we want to do things that are going to decrease their exacerbations and hopefully improve their quality of life. So we're going to go back to our case. So she finally went to a major medical center. It was not our center at that time, out on the west coast. And she was diagnosed by CT scan, lo and behold, with bronchiectasis. And they sent sputum cultures, and she grew staph, Pseudomonas, and MAC.
So what are you going to do now?
Well, I don't know what your tactics are when you see patients who are having recurrent exacerbations and growing multiple organisms, but my first tactic is to treat what's ever easiest to treat. So in this case, we actually treated her Pseudomonas first, and we didn't end up eradicating it. Often you don't. She probably had Pseudomonas for the last 10 years. There are some eradication strategies, and those potentially may be most effective in patients who you've been following cultures for, and then you see their first Pseudomonas happen. And those would entail using oral antibiotics, sometimes IV with nebulized, for a prolonged period of time, sometimes 3 to 6 weeks. But in her case, we gave her a 2-week course for her Pseudomonas. She actually got better, slightly, but then she had another exacerbation. And at that point, when we retested her sputum, at that time, she actually wasn't growing the Pseudomonas any longer, but she was still symptomatic and still had the MAC and still had the staph. And so then we tried to treat the staph, and we eradicated it for a little time, at least on her next sputum. She only had MAC. So ultimately, ended up putting her on MAC with 2 purposes there. One, to treat her MAC. She had macrolide-sensitive MAC. This is not a MAC talk today, but important to get sensitivities on your MAC, because she had been on azithromycin many, many times over the years, and we know that sole therapy with azithromycin can lead to macrolide-resistant MAC, but she was still sensitive to both azithromycin and to amikacin, and she ended up getting treated for her MAC for 2 reasons. One, I didn't know if the MAC was possibly the cause of her progressive symptoms, but I also wanted to give her a course of azithromycin, and we know we can't do that alone in patients who have MAC. Again, we don't want to make them resistant. So she ended up on triple therapy, azithromycin, ethambutol, and rifampin 3 times a week. Yeah. And actually, over the next month or 2, started to improve and didn't have any exacerbations for the next year. I didn't know if it's because we eradicated the MAC or if it was the azithromycin that was causing some anti-inflammatory effect. We'll get back to her, just to tell you that wasn't the end of the story. And even though she got better initially, she ended up relapsing beyond that. So we'll talk about her relapses in a little bit after Jamie talks to us about some of the other modalities that we can use in these patients other than antibiotics.
That was awesome. Thank you so much. So again, I'm the pulmonologist that's in love with immunology. So we're going to talk about the role of neutrophilic inflammation in bronchiectasis. I live just an hour and 10 minutes up the road in Newport Beach, and that's where my practice is. So when we look at bronchiectasis in general, as Dr. Addrizzo just said, there is a lot of airway destruction that happens, which is what leads to the bronchiectasis, right? And we know that when we look at the airway, we know we have airway epithelial cells that line that airway, and we get a lot of mucus production, abnormal mucus clearance, bacterial colonization, and then the neutrophils come and they're trying to defeat the bacteria, they're trying to do their thing, but they just stick around. And you get this vicious cycle, vortex, whatever you want to call it, and it becomes this chicken or the egg. Well, what came first, and what's happening, and what's going on with the neutrophil, what's going on with the bacteria, how are we going to battle that? And so when you go into this and you really start to look at the science of this, we know that about 70% of bronchiectasis patients have neutrophilic inflammation. About 20 to 30% may have eosinophilic inflammation. But then you start to think about cytokines, right? Which cytokines are involved? Which cytokines are making that phone call to get the neutrophil there? And what's the neutrophil trying to do, and why can't it do what it's supposed to? And what ends up actually happening is within the granules of these neutrophils, right, you have loads of molecules, and you end up producing a lot of neutrophil elastase, cathepsins, and protease. And what these molecules actually do is they lead to damage and destruction of the extracellular matrix, and they also activate matrix proteases, metallomatrix proteases, which end up damaging the airway even more. And then they activate more release of interleukin 8 and interleukin 6. You get more recruitment of neutrophils. You get a little bit of monocytes. And you have this inflammatory cascade that becomes a real problem, right? And so what we look at when we understand that the molecules that are activated are causing this problem, these molecules present in this neutrophil are causing this problem, you start to study that, and you're like, well, what if we could tell this molecule to relax? What if we could tell these molecules to calm down? We know that neutrophil elastase is associated with severity of bronchiectasis. We know that the higher the neutrophil elastase in the mucus in your sputum, the worse your bronchiectasis is, the more likely you are to exacerbate. We know that. And so we started to think about these neutrophilic serine proteases, neutrophil elastase, there's cathepsins, there's other antimicrobial peptides that are involved here. And then, as I mentioned earlier, you have the eosinophils, which may be involved as well. And so when you start to think immunologically and what's actually causing this issue, you can arrive at the point of, all right, I think we have a plan. I think we know what to study, because we know this disease is heterogeneous, but we also know that immunology is playing a role. Again, treatments can place a large burden on these patients. They're on multiple antimicrobials. It was really interesting to hear what Dr. Addrizzo-Harris does in terms of treating these organisms, right? Treating the easiest one first and going from there and seeing if the exacerbations happen again. In the process of doing that, you may develop antibiotic resistance, as she just said. And again, when I look at a patient as a kind of a immunology, pulmonary guy, interstitial lung disease guy, I really look at the patient. I have an individualized treatment approach. When you look at bronchiectasis in general, there's really no FDA-approved treatments for non-cystic fibrosis bronchiectasis. There just isn't, right? And so what we do is we support patients. We clear their airways. We wait till they have infections. We get an answer for what kind of organisms are there. We treat those infections, right? And then we use some anti-inflammatories, whether we're using inhaled corticosteroids, whether we're using the anti-inflammatory properties of azithromycin. Either way, we're trying to reduce the symptoms and prevent exacerbations. But as I've said a bunch of times today, you still have an unchecked inflammatory response that's continuing to go and go and go. And this is probably what has led to the patient's presentation of continued exacerbations. And I know Dr. Addrizzo is going to get into this, but this is something that I care a lot about, because when I think about medicine and I think about our stepwise approaches to treatment, it's really, we kind of just wait for the patient to have symptoms, and then when they have symptoms, we add something else. And then when they have more symptoms, we add something else. And we're continuing to chase our tail when it comes to some of these medical conditions. And in bronchiectasis, that's kind of what I felt like I was doing when I was treating these patients. We're going to try to protect their airway, right? So vaccination is extremely important. Vaccination against common organisms like influenza and pneumococcus, and I'm sure in the older population, RSV is probably included in this now, because you want to prevent that inflammatory response. When you look at these viruses that present and infect the epithelial cell, especially RSV, it may even activate type 2 inflammation because you have an inhibition of type 1 inflammation, because RSV produces these non-structural proteins that inhibit that interferon response. So again, this is going to aggravate that inflammatory response, so you really want to treat these patients and help them not be exposed to things that can cause and wreak havoc. Pulmonary rehab is important. Prompt treatment of exacerbations is important. Does your patient have access? Are they going to be able to approach that bronchiectasis expert quick enough? Because some of these patients, if they don't, they may end up in the hospital. They may have an organism that's resistant. when we look at the severity of bronchiectasis, we just keep adding more therapies, daily physiotherapy, then we'll add some macrolides and some inhaled corticosteroids, then we're gonna add oxygen, and we start to think about lung transplantation when those patients are severe, but it's just an issue. How are you going to interrupt that cycle? So if we know the neutrophil is involved, and we know that neutrophil elastase is involved, we also know the molecule that activates that neutrophil elastase along with the cathepsin and the proteinase 3. And that molecule is dipeptidopeptidase. So what happens in the development of the neutrophil, and I'm just gonna go back a couple slides, is that dipeptidopeptidase is actually involved really early in the maturation process of the neutrophil, and you can see it here at the promyelocyte level. That dipeptidopeptidase is activating those serine proteases pretty early in its development. We know neutrophils last hours, so this is happening daily, right, as you're making your neutrophil. So what these investigators did was they developed a DPP-1 inhibitor, right, a dipeptidopeptidase inhibitor. And what this inhibitor did is it targeted neutrophil elastase because we wanted to block the inflammatory capabilities of that molecule, because we know that that molecule activated those matrix metalloproteinases, and it activated a significant inflammatory response, more interleukin 8, more interleukin 6, more TNF. And so we wanted to block that vicious cycle from happening. On your iPad now, you have another question. So before we move on, I'll give you a couple seconds to kind of get through the question. Again, these questions we have to do when we're doing our CMEs. I know we all do them online. We have to answer those 3 to 5 questions to get those CMEs that we have to get in our respective states. So I'll give you guys a second. And I really like this video, and because it really goes through that pathophysiology of non-cystic fibrosis, bronchiectasis. And are we playing it now? During the normal process of normal respiration, air travels through the nose, down the trachea, and into smaller airways called bronchi. The bronchi are going to divide into smaller bronchioles, and then they further lead to tiny balloons, right? They're balloon-like clusters that we call alveoli. In the alveoli, oxygen is exchanged for carbon dioxide in the blood. Bronchiectasis results from the destruction and widening of the bronchi due to recurrent inflammation or infection, which incites an immune response that includes the release of neutrophils, lymphocytes, and macrophages within the bronchial lumen. This results in the airways becoming abnormally enlarged. They get damaged. This inflammatory damage then stimulates the formation of excess thick mucus in the enlarged airways. The thick mucus then crushes the cilia that line the airways and causes further damage. This affects the lungs' ability to rid the airways of dust and pathogen, and quantities of sputum that subsequently form cannot be efficiently cleared. This leads to a recurrent cycle of infection and inflammation, promoting progressive airway damage. Dipeptidopeptidase, or DPP-1, is a lysosomal cysteine protease responsible for activation of neutrophil serine proteases, or NSPs, in the bone marrow during the neutrophil maturation cycle. NSPs are increased in the sputum of patients with bronchiectasis. Brensocatib is an oral small molecule under investigation for the treatment of bronchiectasis that acts to inhibit DPP-1 and interrupt the neutrophilic inflammatory processes in the lung, thereby reducing the number of exacerbations caused by bronchiectasis. I don't know who that person was that was narrating that, but that guy was terrible. So when you actually look at this data on brensocatib, what you see is when you inhibit dipeptidopeptidase, you're increasing that time to that first exacerbation. Now, in this study, these patients had to have at least 2 exacerbations the previous 12 months. They had to be able to produce sputum as well. So these patients are sick, right? They had 2 exacerbations that previous year. And as Dr. Addrizzo-Harris just mentioned, when you have those exacerbations, that increases your bronchiectasis severity. So these patients were really, really sick. But what they discovered was that using brensocatib, it reduced the number of exacerbations in the patients that were treated with the product, and it increased that time to that first exacerbation. When I say it reduced their number of exacerbations, you can see here when you compare it to placebo, there's just less exacerbations in that treatment group. And you can see that really with both doses of brensocatib, the 10 milligram and the 25 milligram dose compared to placebo, which, again, for me as an immunology guy, when you can apply immunology and see how disease can calm down from a physical manifestation standpoint, it's really important. And earlier, I got asked the question of, why do you think this happens? Well, why do you think patients aren't diagnosed soon enough? A lot of times I feel like in our day, in our busy day, we may not take that time to think on a cellular level. We're treating physical manifestations of illness all day long. But I think it's really important for us to get back to our medical training days and think from cell-to-cell communication standpoint and ask ourselves, okay, wait a second, let me take a second. Why is this happening to my patient? Is there something cellularly that's going on? And do I need to spend a little bit more time thinking about how I can help them? I think it really, really helps. Again, I have students in the clinic with me, and I always try to educate and give talks because I think it almost forces me to take my time and to think about things on a cellular level, because understanding those things on a cellular level allows you to understand those physical manifestations of illness, which I think is really important. And here's what you can see here on the cellular level. You can see the sputum neutrophil elastase concentration go down almost immediately after you start taking this medical therapy. After you start brensocatib, that neutrophil elastase concentration goes down. Why is that important? Well, neutrophil elastase concentration is associated with severity of bronchiectasis and exacerbations. So it's really important to see this. And again, you understood the problem immunologically. You understood what dipeptidyl peptidase was doing. You understood what neutrophil elastase was doing. And now here you are intervening on a cellular molecular basis, and you're improving a patient's outcome, which I think is great. When you look at the severity of events, if you look at placebo, of adverse events, when you look at placebo compared to treatment therapy, they're on the order of the same, right? There's not a whole lot. I mean, look at the severe events. There's way more in the placebo group here. So again, it's a tolerated therapy. It was granted breakthrough therapy designation by the FDA and PRIME by European Medicines Agencies. There's 1,700 patients enrolled, randomized to receive 10 milligrams or 25 milligrams or placebo once daily for 52 weeks. And again, the primary endpoint was the rate of agitated pulmonary exacerbations over that 52-week period. I believe they've completed, and the top-line data is expected a little bit later this year. We were hoping for now-ish, but a little bit later this year. There's another question to answer. And again, more immunological data. So secretory leukocyte protein inhibitor, right? That's what this is, this SLP1. So what's interesting about this molecule is that molecule actually reduces MUC5A. MUC5A is a really dense mucus that likes to tether to that goblet cell. So that's what SLPI actually does, and you can see that concentration kind of go up at the initiation of therapy. The other thing you can see is this defensin 3 concentration. Now, the defensins are molecules that help fight infection. They can help fight viruses. They can help fight bacteria. And so you see that concentration go up as well. So these are just molecules that go up as you inhibit that neutrophil elastase. And these molecules are really associated with good, right? So they inhibit that mucus production, and then they increase your ability to fight off certain infections. So this is just cool to see, and this was presented, I think, this week. And then there's other emerging therapies. You've got inhaled immunoglobulins that have been developed, inhaled IgG. You've got phosphodiesterase 4 inhibitors, which can inhibit some of the migration of the neutrophil into the airway. You've got anti-IL-5. Again, 20 to 30% of these patients may have eosinophilic inflammation. You've got another DPP-1 inhibitor. And then you've got CXCR2 antagonists, which that may not work very well. But again, that's inhibiting the ability of the neutrophil to get into that airway. And so all of these things are very important as we study this condition, because there's just not any FDA-approved therapy. I think there's one more question there for you as we move on. I think we bring you back.
Is it me?
And I think it's your turn.
And I'm back. All right. All right, so let's get back to our patient. She was treated for her staph and Pseudomonas, as I said, then a longer course of NTM. She did well for about 6 to 9 months, and then her Pseudomonas came back after her NTM cleared. We always see this. We get rid of one organism, and then the other one starts to grow again. And at that time, we had multiple options. She was having progressive decline in her pulmonary function studies, and we could have tried some of the inhaled antibiotic therapies for chronic Pseudomonas in patients who have frequent exacerbations, more than 3 a year, but she hadn't for the last year actually had an exacerbation because she had been on this treatment, so she really didn't exactly qualify for inhaled Toby or Caistin or Colistin. So we did have another option for her, and for many of our patients, we always consider them for clinical trials that are available either at our center or at one of the other centers in the U.S. And so she was able to find a center near her in the West where she enrolled in a clinical trial, Aspen, and she was treated with brensocatib. She was in the trial for brensocatib. I don't know if she got placebo or brensocatib. And now she's in the post-access trial, and now she is getting brensocatib. And she's continued to be treated with airway clearance, and she is back actually on NTM therapy, but has been very stable on her second course of NTM therapy and has not actually had an exacerbation in the last several months. So one option, as we saw, was to treat the easier organisms. I didn't tell you about her airway clearance saga, but it took a while for us to get her on an airway clearance regimen, and that should always be one of the first things you think about in patients with bronchiectasis who have productive sputum and who are having exacerbations. Not one size fits all. She had trouble doing hypertonic saline, and that was actually causing her additional exacerbations and bronchospasm. So she actually ended up being on oscillatory vest therapy, an exercise program, and chest percussion, which actually helped very well. So you need to try a lot of different therapies in some of these patients, because not one therapy can, not every patient likes each of the therapies, and sometimes it's a different combination for each patient. We have another question. Jamie lied. There was one more hiding there. Okay, so please take this question on challenges in managing non-CF bronchiectasis patients. And I will summarize, and then we will go on to some of the questions that you've been submitting. So we know bronchiectasis is characterized by this vicious vortex cycle of infection, inflammation, and injury that often results in progressive symptoms, loss of lung function, loss of activities of daily living, and poorer quality of life. The diagnosis is often missed or delayed for many years. Chest CT is the gold standard for diagnosis, and you want to think about some of these novel agents that target underlying inflammation, and think about clinical trials for your patients if they have access to a center where they're occurring. All right, so it's time for your questions, and I will start with one for Jamie. Dr. Rutland, does the reduction in neutrophil elastase via DPP1 also reduce PA? Don't know what PA stands for.
Oh,
Oh, Pseudomonas, thank you. Okay, Pseudomonas counts in lungs of patients. So do we have that answer from the studies?
I don't know if we have that answer from the studies. I would assume if these patients had grown Pseudomonas previously and they're having less exacerbations, I don't know if they're getting I don't know if they're getting cultured every so often anyway. So I wouldn't be able to answer that question, I don't think.
No, and I don't think I have the answer for that either. I do want to point out, as many of you in the audience probably have to deal with all the time, when you see Pseudomonas, does it need to be treated is the first question, all right? And which patients need to be treated? So again, not a good guide to follow. I mean, if somebody is clearly ill at the time and having an exacerbation, I know most of you would treat it. But in a patient who you don't know, you first meet, you see Pseudomonas, maybe they had it 6 months ago as well, when do we treat that patient for their Pseudomonas infection? And I'll often step back and want to follow them closely, 3-month follow-up, get more cultures at a monthly interval, get pulmonary physiology testing, get a CAT scan if they haven't had one recently, and find out, is that Pseudomonas causing them a progression of their disease? If it isn't, and their symptoms are relatively minor, then we'll just monitor them. And many of the patients out there have Pseudomonas for years and don't get treated for it. So I think it's really just getting to know your patients as best you can and getting frequent cultures, because that Pseudomonas may change to Haemophilus or may change to Stenotrophomonas or an Acinetobacter, and then the patient may have different symptoms. So it's, again, a lot of communication and a lot of follow-up with sputums. Let's see, how strong is the evidence that reflux causes bronchiectasis and that treatment of reflux reduces exacerbations? So again, not a lot of good evidence out there. Our center is studying patients with, most patients who present to us have a full assessment, a GI assessment for swallowing disorders and for asymptomatic reflux. Obviously, if they're symptomatic, they're usually already being treated. And so we're gathering some of that data, but we do know that patients with lower lobe disease can often be aspirating, whether it's from the upper pharynx or from recurrent aspiration at night from GERD. Manometry studies sometimes can be extremely helpful, particularly in the asymptomatic patient. It's hard to tell someone to change their diet, to not eat 3 hours before they go to sleep, to put a wedge under their bed so their bed's elevated. Most patients are not going to want to do that, especially if they're asymptomatic, unless you show them some evidence that they are having increased reflux or aspiration. There are a few cases. We presented a case at last year's ATS of actually in a severe patient doing a Toupet fundoplication procedure, which is a 270 procedure, 270 degrees of the distal esophagus. Our minimally invasive surgical team does it to tighten up the esophagus, reduce reflux asymptomatic in patients where pharmacologic therapies weren't helping and day-to-day changes weren't helping. And we saw a significant decrease in exacerbations, as well as significant improvement in pulmonary function testing. So that's going to be something I think you're going to be seeing coming out there and looking a lot more at these patients who have asymptomatic reflux. Do you want to add anything to that, Jamie? Okay, did COVID-19 lead to a higher incidence of bronchiectasis, and did it lead to more challenging management? You want to?
Yeah, I mean, I don't think I saw a higher incidence of bronchiectasis. I certainly saw bronchiectasis in long COVID patients and patients that had continued inflammation and some scarring, but I don't know if it was the clinical bronchiectasis that we're speaking of right now.
And I would have to say, since most of my patients were staying home, they weren't having as frequent bronchiectasis exacerbations, and there's some data out there, and I think that's just because of the infection control that was going on. So they certainly weren't getting sick as frequently. I have a question here. Which patients with bronchiectasis benefit from inhaled corticosteroids? And so that's a good question, right? We want to shy away from using inhaled corticosteroids, but there are patients who have significant bronchospasm that often do benefit. So I think the first thing I do when I see a patient who comes to me who's already on inhaled corticosteroids and they're looking okay, all right, and they're not that severe, we'll stop them. And then we'll just monitor them very closely with PFTs and symptoms to see if that was really making a difference. Sometimes just a LAMA or a LABA or a combination might be enough. But we probably have about 20% of our patients that do need inhaled corticosteroids and benefit from it. Some of them have overlap syndromes because they've got COPD or asthma and bronchiectasis. So I do think the first thing to think about is what's the lowest dose you can have them on that will help their symptoms. And if you can get away without using it, try using a LAMA or a LABA combination.
I like this. I think there's two questions here that can kind of go together. What are your thoughts on endotyping bronchiectasis? Would you do lavage? Given that we can't order neutrophil elastase, is there a surrogate marker like neutrophils or CRP or something else? So the way that I would tackle this question is when you do a bronchoscopy and you do the lavage, the way that I do it is I will make sure that the airway is kind of free of the mucus if there's a significant amount of mucus there, and then I'll do the lavage, and then I'll do the cell count and differential. And then if there's a significant amount of neutrophils, I'm going to assume that neutrophil elastase is around because the patient has a diagnosis of bronchiectasis. That's what I do. If I see evidence of, or if I'm looking for type 2 inflammation, and I see evidence of an increased eosinophil count or an elevated IgE or an elevated phenol or something like that, and there's an opportunity to intervene using other means, I may do that as well because some of those therapies are already approved. Because again, when I look at a patient, I'm trying to define what their protoplasm is doing, but I'm also trying to help them. So I'm going to do what I can to help them. But that's what I do, is I try to get as much objective cellular inflammation as I can to decide on what therapies I believe would benefit the patient.
Right. Someone is asking about the role of MRI, chest MRI for screening, and unfortunately at this point, MRI is not helpful for lung pathology. So we can't get away from the radiation exposure, so that's why getting to know your patient and obviously using CT, but using it as minimally as needed is what you would want to do. Do you quantify the amount of non-CF bronchiectasis or peribronchial inflammation on the CAT scan? And how actually do you screen for progression of disease? So I don't think we're not counting it to the level of the bronchiole that's involved, but we do use number of lobes that are involved with disease. That's what's being captured in the US bronchiectasis registry, and there have been several publications. The more severe, the more diffuse the disease is, with the larger number of lobes involved, often the more severe the disease is. And obviously, in most patients who are ill with bronchiectasis and in that moderate to severe group, we're usually getting CAT scans on an annual basis, with pulmonary function tests often more frequently, maybe every 6 months, and again, monitoring for sputum. And so combined with their physiologic status as well as their CAT scan status, we will clarify whether they are stable or they're progressing.
Why doesn't the BSI include cough as a severity marker?
I don't know. We'll have to ask Dr. Chalmers that question. I'm not sure. Hard to quantify how much cough patients may have, right? I know there are newer devices coming out that are going to give us a good feeling for the type of cough, and maybe the device can tell us, and maybe with AI we'll be able to figure out, oh, that cough is related to asthma, but that one's related to bronchiectasis. But I don't have an answer to that question as why it wasn't included. Why is the prevalence of bronchiectasis higher in females, and is there a hormonal mechanistic factor contributing? There may be. I don't think we know that for sure. A lot of the genetics as well around bronchiectasis are now really being better defined. A lot of the CFTR deletions, duplications, et cetera, are starting to be measured in some of these patients with severe disease. And so I think probably some of these answers, whether hormonally related or genetics, are going to be coming out sooner than later.
There's a question that said, what do you do about asymptomatic bronchiectasis that's incidentally found on CT?
Depends on how much asymptomatic bronchiectasis there is. A thorough, if it's in multiple lobes, we're going to do a full workup and watch the patient and just monitor. And I think the most important thing here is just to identify the disease and then clinically monitor. Not everyone needs to be treated, but if you tell them, bye, I'll see you, call me back when you're sick, by the time they're going to call you back and be sick, we're going to know that it has progressed. So monitoring them and just, continuing that communication and that clinical care, I think is very important.
I look at patients individually there. So like say if somebody's asymptomatic and they have bronchiectasis in a couple of lobes, they're asymptomatic, they got a cardiac CT, say they're 47 or 50 years old or something like that. I might do a bronch, right? I might culture the airway. I might do these things. I might look at the cell count and differential and kind of understand what it is that they're battling, because I only have the patient for that 15-minute period. It might be the only time that they come in before they end up in the ER or they end up in the hospital. So I'm probably a little bit more aggressive with younger people just because they have, theoretically speaking, a longer life to live, right? So for me, I try to do those things to just identify the inflammation, identify an organism, so at least I know what to treat. And I'm like, oh, well, this is what they grew. Let me treat them for this.
No, and I agree. I think the younger multiple lobe disease patient who's asymptomatic, very important to try and find the etiology. And I would say that we love to do induced sputums. There's almost no one where we can't get sputum out of with an induction.
Right.
So real good induction and huff coughing and post-induction procedure, respiratory therapy procedures can be very, very fruitful, but it takes a lot of time, and you have to be with your patient. So if we can't get sputum, because Jamie's right, identifying, are they colonized with Pseudomonas? Is there MAC there? Is there something else that caused what we're seeing on CT? Good to know about it before they start to get sick anyway, and then you can make an educated decision as to, should we try and treat this? They're young, they've developed this already. It probably was there for years already. So the more information you can get up front, the better. If it's really not multilobar and it's in one area, maybe they had an infection when they were younger and it's just post-infectious and they have no symptoms, you can certainly follow them clinically in those cases. All right, I think our time is done. I hope you enjoyed the session this evening, and thank you so much for your attention.